Hi, Dr. Dan Sullivan here with the Sullivan Group. And this is case number 3 in our abnormal vital sign series. And we are going with a pediatric patient here in our case number 3. If you have just looked at the previous vital sign videos, then fast forward through the next couple of slides. If you have not seen the first few videos or you haven't seen them in a while, you may want to listen to this. Big picture intro, why the focus on abnormal vital signs? Because the number one medical error in emergency medicine is the failure to diagnose. The number one cause of medical malpractice in emergency medicine is the failure to diagnose. And after decades of analyzing thousands of failure to diagnose cases, the failure to recognize and or act upon the presence of abnormal vital signs is a major contributor to the number of failure to diagnose cases and to medical malpractice. This series of videos is designed to assist the ED team keep the vital sign issue front of mind, reduce the frequency of medical errors, and keep our patients safe. Is it a dangerous thing, discharging abnormal vital signs? Does it impact outcomes? Yes. I've got a couple of references here. I've got a page full of references. Start this with abnormal vital signs at discharge increase the likelihood of admission and death. They are predictors of unexpected deaths after discharge. They produce more undesirable process outcomes. Specifically, patients with tachycardia, tachypnea, fever, they're more likely to bounce back within 72 hours and be admitted. Study pediatric patients. 17% of all peds patients were discharged with at least one abnormal vital sign, a relative risk of 2.5 for adverse events. And abnormal vital signs going home, qualitative factor in patients who die shortly after ED discharge. So, focus on abnormal vital signs at discharge, really important, a critical issue in the practice of emergency medicine. Okay, we're doing a peds case. Why are there so many kids that go home with abnormal vital signs? Well, there's probably a number of reasons, but one of them is that their vital signs are all over the place. The fetal heartbeat is usually 130, 140, 150, 160. Then we've created a table. This is a Sullivan Group table. And a month, and I want to do just a little bit of background here. Median heart rate, half above, half below for a 1 month old is around 144, 145. So what we've done over here on the right is we've created 2 standard deviations above the median, 2 below. That's most kids for the normal low, the normal high. Above that, 1 more standard deviation gets us to 192, and above that we call panic. What we're dealing with in this case is an 8-month-old, and so that median pulse, should be 133 plus or minus 10, sort of. And over here is that range, gives us 2 standard deviations above and below, up to 163, and then up to 178 for another standard deviation, and then panic above 179. So I want you to see that because it's confusing. In a 3-year-old, what should those vital signs be? The nurses don't know, the doctors don't know, the APPs don't know, and so off kids go with abnormal vital signs. All right, well, so let's get into this case, and we'll get back to the data in just a minute. But this is a kind of a sad case. This is an 8-month-old female presented to the ED with fever, irritability, and vomiting. The child was taken immediately back from triage and evaluated by the ED nurse at 21:15. Chief complaint: fever, irritability, vomiting. HPI: parents note from home a fever of 103 and irritability for 12 hours. And general, 8-month-old, no apparent distress. Pulse, initial pulse from the nurse, pulse 198. Rest 44, temperature 103.6 Fahrenheit. Lungs clear, heart fast, abdomen soft, non-tender, neurologic, age appropriate. So let's flip over to the physician. Chief complaint: fever, irritability, and vomiting. History of present illness. Repeats the temp and irritability over 12 hours. Poor feeding. No cough, sore throat, diarrhea, rash, seizure, headache, etc., etc. I want to point out here that this is probably an EHR macro. This is sort of an aside, but this is probably an EHR macro because you don't ask 8-months-old if they've had a headache. So that casts doubt on the veracity of this chart because, hey, kids and headaches, you don't ask that question. So that's an important issue. And there's another one here. On physical examination, vital signs per nursing notes, no acute pain or stress, interactive, playful, non-toxic. Great statement. Eyes fine, ENT fine, throat fine, no meningeal signs, supple, respiratory fine, normal PMI, neurologic. Okay, let's look at the neurologic. Alert and oriented, an 8-month-old. Cranial nerve exam, 2 to 12. Again, obviously a macro, a smart phrase, a dot phrase, something. This is not a neurologic exam on an 8-month-old. And if you wind up in court with this, plaintiffs will be all over you, and they will call this into the question. They will call your care into doubt. Anyway, the rest of the on skin is important. Normal to inspection, no rash. Okay, let's keep going. The only thing in the basic metabolic profile, CO2 is a little bit low, and everything else is good. White count within normal limits. Urinalysis normal. Chest X-ray is normal. Okay, let's run through the ED course here. So this is the nursing progress notes in their entirety. 2140, try an IV stick, which was unsuccessful. Blood was ultimately drawn and sent to the lab. Cath urinalysis. Took some Pedialyte, waiting for laboratory results. Asleep, sent to X-ray. 0030, patient's awake and alert. Mom says now acting like herself. And patient tolerated Pedialyte, great. That's a great comment. Consoled by mother. No apparent distress. Discharge instructions for fever and Tylenol dosing discussed. Discharge vitals. Temp is down to 101.1 with a heart rate of 190. This is the absolute key to this case. Temp is down, heart rate went from 198 to 190. All right, this child was discharged at 0130, 1:30 in the morning. Parents found the child the next morning to be lethargic with a rash, returned immediately to the ED. Child was lethargic with a petechial rash, head, torso, and extremities. Child did not withdraw during 2 sticks for IV and labs. There was a delay in obtaining transfer. The pediatric intensivist at the receiving hospital insists the ED doc give antibiotics and do an LP, which you probably should have done without being asked. The LP showed a lot of white blood cells in the CSF. CSF later revealed meningococcal meningitis. The ultimate diagnosis was meningococcemia. The child survives with permanent hearing loss and mild cognitive dysfunction. In the subsequent litigation, interesting, the jury found that there were multiple breaches in standards of care, I agree, but they did not result in injury to the child. The jury believed that the child had meningococcemia on the first visit, just wasn't completely manifest, and the child would have had these injuries anyway. It wasn't the practitioner's fault. So the defense won in this case. All right, back to the literature to look at those heart rates in children and the impact that temperatures have on them. So we're going to do this with a 1-year-old because that's as close as we can get from the literature. But in a 1-year-old, every increase in the temperature of 1 degree Celsius in a 1-year-old will increase the heart rate by 13.38 beats per minute. Corollary, for Fahrenheit, 1 degree of temperature increases the heart rate by 7.36. All right, so here we are back to our data. Most kids this age start with a pulse of around 132. You can, plus or minus 10, 15, 20 on top of that, but the child should have been, normally they would have been at 132. At 164 to 178, that would have been abnormal. And 179, 3 standard deviations beyond the median is panic. And this child had a pulse of 198 on arrival and 190 at discharge. So the first point is that the child's heart rate was extremely elevated. Even if you don't know every age group, the gestalt should have been, this is really high. We know from the table that it was beyond 3 standard deviations, which we consider very abnormal. This child was discharged from visit 1 with a very abnormal pulse. But the child was febrile. Maybe the pulse was high because the temperature was elevated. So let's do that math. The initial temp was 103.6 Fahrenheit. Median temp for an 8-month-old is 133. And so do the math, multiply that research-based change in Fahrenheit of the 3 degrees. I'm sorry. In this case, there was a 5-degree difference. 98.6 is normal, up to 103.6 is 5, times the 7 beats per minute for every degree Fahrenheit. That pulse should have gone up 35 from baseline, which for most kids this age would be 133. Okay, child's heart rate should have been in the neighborhood of 133 plus 35, 168, and it was 198. All right. Now, for the sake of argument, let's just say that this child was baseline heart rate, resting heart rate, was, remember, 133 is like most kids are, 133 plus or minus. Let's go all the way out 2 standard deviations to 163. Let's say the resting heart rate was 163. And then let's add that 35 because of the temperature. What does that equal? Well, 163 plus 35 is 198. That's exactly what this child was. So, that's kind of an issue here. Still this seems, way out of bounds for a heart rate. But, I might even argue this in court if I was challenged that at the highest area that we consider normal, plus 35, maybe that initial pulse could be, maybe considered within bounds. All right, but consider the discharge temp and heart rate, 101.1 and 190. So if you take the median of 133 and you add 17 beats per minute because of that 2.5 Fahrenheit increase, that pulse should have been 150. For most kids who'll be living at 133 at this age, that pulse should have been 150. If you go all the way to the top side of normal here and you add that 17, it's 180. And this kid went home at 190. This child should not have gone home. The heart rate was too high, and there was a disparate pulse and temperature. And that is a concept we should be familiar with and that we should be working with. This child should have had, summary and conclusion, this child should have had an immediate septic workup based solely upon the parent's complaint and initial vital signs. They said fever, they said irritability, they said vomiting, temperature 103.6, tachycardia, should have raised a lot of red flags. The initial temp for an 8-month-old was in the panic range of 198. When the temp came down to 101.1, the pulse remained very high at 190, still in the panic range. If the tachycardia was related to body temp, the pulse should have dropped significantly between arrival and discharge. The child was discharged with a very abnormal pulse, visit 1. At discharge, the child had a huge pulse temperature disparity. What else is cooking with this case? Irritability and lethargy equal sepsis, meningitis until proven otherwise. What else? Watch your EHR macros. An 8-month-old is not going to tell you they got a headache, and they're not going to work with you on a cranial nerve exam. You cast doubt on one part of your documentation, you cast doubt on all of it. There were several opportunities to consider sepsis during visit number 1. The vital sign abnormality, the pulse temperature disparity should have put sepsis and meningitis squarely in the differential diagnosis. That's why we have this heavy focus on these vital sign cases. It's such a critical issue in the failure to diagnose and in medical malpractice, medical error, and keeping our pediatric patients safe. Thank you.